afternoon, everybody. Welcome. So today is National Advanced Care Planning Day, and we're super excited to see so many of you joining us today for this webinar. So the webinar is Advanced Care Planning, Substitute Decision Makers, Healthcare Consent, the Who, When, and How. So my name is Stacey Fremantle. I am the Covering Community Development Lead for the Northwest Regional Palliative Care Program. I'm joining today from Thunder Bay, Ontario, and would like to acknowledge that this sacred land has been the territory of the Anishinaabeg Nation and is home to the Robinson Superior Treaty of 1850 territory. I recognize that Thunder Bay is still home to many Indigenous peoples from across Turtle Island, and I am grateful for the opportunities we have to work together in this community and on this territory. This webinar is being offered in conjunction with the Center for Education and Research on Aging and Health. The presentation is being recorded, so has already started being recorded, and it will be added to Sarah's Education Archives after the session. So that being said, you may wish to turn off your video if you would prefer, and we do please ask that you leave your microphones on mute throughout the presentation. We did receive a lot of fantastic questions through the registration, the online registration, and the intent is that we will try and address those questions during the presentation. If additional questions do come up throughout the presentation, we ask that you just please hold them until the end of the presentation, and then Jill will respond to them then if we have time. You can always also add your questions into the chat box at any point during the presentation. If those questions are not answered during the presentation, then we will try and address them as well once the presentation is over. If there are any unanswered questions at the end of the presentation and the end of the session, please make sure that they're in the chat, and we will do our best to follow up and possibly email an answer out to you so that we're following up. We will also be sending out a copy of the presentation slides, so you will receive those after the session for your reference as well. So I think we're just going to jump right in. It is my pleasure to introduce our presenter today, Jill Marcella. So Jill is the manager of the Northwest Regional Palliative Care Program with St. Joseph's Care Group. She's a registered social worker with a specialization in gerontology. Jill's current role focuses on working with system partners, healthcare providers, clients, and families in planning for and creating coordinated system of palliative care accessible to all individuals living with a life-limiting or terminal illness wherever the individual lives. Jill is an education facilitator for learning essential approaches to palliative care, so the LEAP program, palliative care for frontline workers in Indigenous communities, leads in a caring environment, and is a regional champion with Hospice Palliative Care Ontario for healthcare consent and advanced care planning. So welcome, Jill, and thank you so much for joining us today.
Great. Thank you so much, Stacey, for the introduction, and happy National Advanced Care Planning Day for those who are taking the time to join us. I'm getting some pop-ups on my screen.
Oh, you're on mute, Jill, but you're back.
Stephanie, I'm wondering, I'm going to stop sharing. As soon as I tried to share, everything started getting glitchy. So would you mind sharing the slides?
Yep, not at all. Just give me one moment.
I'm wondering if it's just too taxing for my computer here at work to do both. Once again, happy National Advanced Care Planning Day, and thank you for the introduction. And I will try and stay on time, as I tend to be rather verbose. And I really do thank those individuals who sent in questions, because it really did help inform how we laid out our presentation. So just to begin, kind of as a disclaimer, I am not a lawyer. So all of the information that I'm sharing today is not legal advice, but it really does come from my background and experience in working in social work, working as being an HPCO, advanced care planning champion and healthcare consent champion. But my passion for advanced care planning really does come from previous role I did a long time ago, where I was a fee-for-service rights advisor with the Psychiatric Patient Advocates Office of Ontario. And it was at that time that I really, I think what resonated with me was the importance of this information for people well in advance of any illness or being introduced into the healthcare system, and how vulnerable people are. And from that role, I really became passionate about learning more and doing what I could in the way of building healthcare providers' capacity to have these conversations and what their knowledge is around healthcare consent. So if you want to flip to the next slide, Stacey or Stephanie. So really today we're looking at some of the frequently asked questions around advanced care planning, with hoping to have an greater understanding of advanced care planning within Ontario. So focusing on the Ontario legal framework, clarifying the substitute decision maker hierarchy and consent, and building maybe some of those communication skills that you have with families and clients around advanced care planning, and being able to apply advanced care planning in your clinical practice. Next slide. So when I talk about the Ontario legal framework, there are a couple of pieces of legislation or acts that really fall within that, and that is our Healthcare Consent Act, our Substitute Decision Act, and what's within those acts. So advanced care planning in and of itself doesn't have its own act. We have the expression of wishes in the Healthcare Consent Act, and then we have substitute decision makers and the roles of substitute decision makers and what their authorities are outlined in the Substitute Decisions Act. And as we move into the questions that were submitted, and you think about your role with advanced care planning, one of the things that I heard recently from a palliative care physician, Dr. Jeff Myers, who's done a tremendous amount of work around building capacity and knowledge in healthcare providers and helping them distinguish between what's an advanced care planning conversation versus a goals of care conversation versus healthcare consent. He said something that really resonated with me in trying to break down some of that complexity. And when we're working with clients or patients, it really is our interaction going to be about preparing them? And is it a preparation conversation, or is it a conversation which is going to require a decision, or are they going to have to decide about something? And I think that really breaks down some of the complexity quite nicely. Next slide. So for advanced care planning and what it is, it's really two important parts. In Ontario, it's about confirming who your substitute decision maker is, and it is about the conversations that you're having with your family, your caregivers, your healthcare providers, and most importantly, your substitute decision maker about what's important to you. Advanced care planning is not consent. So if as a healthcare provider, we're engaging in a conversation where we're looking for a decision, then that would not be an advanced care planning conversation. That's a healthcare consent conversation. Next slide. So as we go into what and who is a substitute decision maker, I just want to ask the participants on the presentation, do you know who your substitute decision maker is? So if you just want to quickly put it in the chat as a yes, or give a thumbs up with your emojis, just to get a sense of whether or not you know who that individual or who those individuals are. Next slide. So every person in Ontario does have a substitute decision maker. And a substitute decision maker is a person who makes care and treatment decisions on your behalf if and when you become incapable of making those treatment decisions for yourself. So we do have a hierarchy in Ontario called the substitute decision maker hierarchy, and you'll see on this diagram where individuals fall. And what I like about the color coding is it nicely outlines who a legally appointed substitute decision maker is and who our automatic family member substitute decision makers or others might be. So in the first section would be our court-appointed guardian, or if you have a power of attorney for personal care, that would be your attorney for personal care. Or it could be a representative that's been appointed by the Consent and Capacity Board. But I think for most people, most clients or patients that we work with that don't have a power of attorney for personal care completed, which is not a requirement, their substitute decision makers fall within that green section. And it is a hierarchy. So as healthcare providers, we're starting from the top and working our way down. So spouse and or partner could include anyone that is married, but spouse does mean a common law relationship that you will have been living in for at least a year. And two people are partners if they've lived together for a year, have a close personal relationship that is of primary importance to one another. And this can include friends who have lived together for at least a year in a non-sexual relationship and have a personal, close, family-like relationship with one another. And then parents or children, it is both. So if your parents are living and you do have children and they're over the age of 16, say you have two living parents, three children over the age of 16, all 5 of those individuals would be considered your substitute decision maker. And then on down the line, including siblings. So again, if you have multiple siblings, unless you've appointed one or more of them through a power of attorney for personal care, all siblings would be considered your substitute decision makers. And then our substitute decision maker is the public of last resort, is the public guardian trustee. Next slide. So one of the questions we received, I think we may have a slide before that, was who decides if there's no substitute decision maker, and if you do not have a substitute decision maker or a power of attorney for personal care is not able to or willing to or refuses to act on your behalf, then the healthcare provider would go back to that hierarchy of substitute decision makers and pick the next person in line. And if they got to the end of the green line and there was nobody there, then they would go to the public guardian trustee. Other questions we've received around substitute decision makers is whether or not they need to live in Ontario, and they don't need to live in the province that you reside in. They just need to be available and willing. And available, they don't need to necessarily, it doesn't mean they have to be available in person, but they can be available by phone or virtually or any way that allows the healthcare provider to communicate with them directly and in a timely way. And it is voluntary. So I always like to ask people, if you think about yourself and if you know who your substitute decision maker is, do they know that they're your substitute decision maker? But also if you think about that hierarchy and maybe you see yourself on that hierarchy of potentially being someone's substitute decision maker. And if you do see yourself on that hierarchy, have you had those conversations or have you been engaged in any type of conversation with that person that you may be a substitute decision maker for? And again, if you choose not to be, that's fine. The healthcare provider would determine that if they were asking you. But I think it's always good to know whether or not we are a substitute decision maker for someone else. And always really good to know that our own substitute decision makers are aware of that. So the next slide, we had a question around changing a substitute decision maker. So if a person does not have a substitute decision maker, then how does the medical system or hospital decide for a person that is unable? And there was also a similar question that I thought fell within this, is if there's guidelines around changing substitute decision makers. For example, adult children don't think their dad is making the best decision for their mother. What would that process be? So only the capable person can change their substitute decision maker and make a power of attorney for personal care. So the individual has to be capable at the time. And if, for example, you're in hospital as a patient and someone's asking you to make a power of attorney for personal care, they would have to determine that you were capable of making that at that point in time. And then if there was a family member who was disputing the decisions that were being made by the substitute decision maker, then the disputes would go through the Consent and Capacity Board to decide. And the Consent and Capacity Board may appoint someone as a representative if the Consent and Capacity Board determines that the individual was not making decisions in the best interest or following prior capable wishes of the individual. And I've certainly found this when I was working in long-term care, when people would go away and they were the substitute decision makers, they would often say, well, while I'm away, if you need any healthcare decisions, just contact my daughter, you know, the resident's grandchild or the person who lived in town. And they actually don't have the authority to do that. So if there is circumstances like that where people are vacationing and they know that they may not be available to be in that role, really having a clear conversation with the resident, if the resident is capable, of how that decision-making process would look while they were away, because the healthcare provider would be obligated to go to the hierarchy and speak to the person who was highest on the list if you were not available and you were the appointed power of attorney for personal care. Next slide. And then we had a question around when to introduce advanced care planning and what our thoughts are about the when and how to introduce the planning in a person's health care journey. So really it is early is best, and it is an iterative process. So across the whole health trajectory at any point in time, having advanced care planning conversations is a good idea. It really isn't just for end of life. And I always feel really frustrated that advanced care planning has seemed to landed in palliative care and in the realm of palliative care. But really, when we think about it, it should be beginning much sooner. I always ask the question, when do you think advanced care planning should begin? And just out of curiosity, if I could get a sense from the chat and the audience, when do you think advanced care planning it's a good time to introduce? Any thoughts? When you reach the age of being a substitute decision maker. Yes, great suggestion. 16 is when you can become a substitute decision maker or appointed as a power of attorney for personal care. I think 16 is a great time too, even to talk about it as a general conversation. Most people, what do they start doing when they're 16 is drive. And unexpected things can happen, accidents can happen when people drive. So it's a great opportunity to introduce the understanding of what the role is, who the decision maker would be, and general conversation around values and beliefs and what's important. Primary care really does play such a key role in these conversations and beginning them, and then having the opportunity to revisit them with ongoing visits when patients change or health changes across an illness that they might be living with. And it really can be framed within routine care. So whether you're a nurse, a personal support worker, a family member, there always seems to be natural opportunities where these conversations can emerge, and you can have frank discussions about it. I find even when someone has died, there seems to always be a lot of conversation or discussion around what went well with an illness, what didn't go well, especially if it was an anticipated death with someone who was living with an illness for a long time. And I think those are perfect opportunities for people to explore what some of their values and beliefs are. And it really is focusing on being prepared and not having to make illness decisions. Next slide. And then how do you bring up the topic when the person does not want to know they are sick, or if we're talking about palliative care, if we're having palliative care conversations, or just how to begin the conversation in general. So it really is normalizing the discussion using open-ended questions. So I think going back and thinking about your intention of the conversation or the visit that you're having with the individual, And if your intention is that you have an agenda and you need something completed, then chances are you might be disappointed because the person or the individual might not be willing to go where you're wanting to go. So meeting them where they're at and finding out what their illness understanding is. But even before that, just things that are important to them, who their family is, some of those basics, if it's an initial conversation. And really asking about their values and their fears. And then as a healthcare provider, beginning to document those conversations in whatever documentation system that you have. And if the person isn't wanting to talk about their illness, it really is just an opportunity to learn more about them and to let them know that you'd like to come back and revisit some of the questions that maybe they weren't willing to answer at the time, and find different ways to maybe ask the question. Next slide. Another question we often get is, does it require a lawyer? So in Ontario, completing a power of attorney for personal care and a power of attorney for finance does not require a lawyer. These forms can be completed by the individual, depending on your role. If that's something that is part of your role, you could bring the forms and walk them through what would be needed to be completed. And explain it to them and leave it with them. But for complex cases, but in general, I do like to recommend that people do seek legal advice. Just because for things like the power of attorney for finances, if you're going into banks, there might be certain policies in place that they won't accept something that has been completed like the Ontario document. They might require something from a lawyer, but it's also a good idea just to make sure that some of those nuances the individual understands. And sometimes there are legal clinics within communities that are available at senior centers or in public forums that people can be encouraged to go to and actually get some legal advice if they have specific questions. Next slide. And then we had another question about long-term care and considerations for for residents with powers of attorney for personal care, and what some of those considerations are. So just to note that a common misunderstanding, I think, hopefully has been changing, is that even though a resident may be deemed incapable for placement into long-term care, it doesn't mean that they're incapable of making healthcare decisions. So although they may have been incapable to be living in the home, they're still capable of making decisions around their healthcare. So you want to review whatever existing powers of attorney for personal care the person might have. It is not a requirement to have a power of attorney document to be admitted into long-term care. And sometimes that's a misinformation, or people think that they need to have one, or they may even be asked by the home to produce one. But if the resident is satisfied with the substitute decision maker hierarchy and who that individual is, they are not required to produce a power of attorney for personal care. So really confirming the understanding with the resident that the individual is who is at the top of the list, if they're satisfied with that individual and confident that they would make decisions if they were asked and needed, and also explaining that to family members when they're potentially bringing a resident into long-term care. And then being able to have some of those conversations with those initial care planning meetings that residents have to make sure that their care plans align with what their known wishes are. Next slide. So engaging reluctant patients. How do you engage someone who's uncomfortable with death? They give maybe brief answers when you're trying to have the conversation. Or how do you implement or introduce it to someone who doesn't medically require it, but in case of a life-altering illness or incident, or they're going into long-term care, how do you introduce it? So I think To begin with, engagement is really acknowledging the discomfort. They can be uncomfortable conversations. A lot of people don't like to talk about them. Or people will say, oh, my son or my daughter knows what I want, so I don't really have to worry about that. But if you prod a little bit deeper and ask them exactly what it is they know, often you'll find that the individual hasn't really had any conversation with a substitute decision maker around the what ifs, or really what's important to them. If staying in their home independently as long as possible is what their number one priority is, even being able to confirm whether or not they've had that conversation with their substitute decision maker, and how important is it to stay in the home, and what would they be willing to, if they had to have a trade-off, what would they be willing to trade off in order to stay in the home? If it required at some point in time for them to have services in place, would they be willing to do that? Those are easy, lighter conversations that can begin without it having to be focused on the illness, and really using gentle prompts with the individual, the clients, the patients, the families, and really recognizing that it is a revisiting the conversations over time. So I always say that it's not one and done with advanced care planning. They're ongoing conversations that we're having with our clients. Next slide. So a question around the level of detail that's needed in advanced care planning. So there doesn't need to be a required document anywhere. It really is documenting, again, over time, what the individual is expressing as a value or a wish. They can be documented in a medical record. They could, if they wanted to, fill something out. But again, the consent the healthcare provider would be seeking doesn't come from a piece of paper. It's going to come from an individual. So it is going to come from the substitute decision maker. And anything that's written or documented is going to be used to inform and guide the substitute decision maker. So you really want to encourage people to avoid overly rigid directives, because in the absence of what is potentially happening currently, it's really hard to know what those options are. And it would be really hard to enable the substitute decision maker to interpret if what they're talking about now and an incident happens in the future that doesn't look anything like the conversation that you're having now, may not even be the same condition. How is that information going to be used if it's rigid to help that substitute decision maker potentially make the decision in the future? So that's really where the expertise of the healthcare team and the healthcare provider in the future can support the substitute decision maker with the information that they've had over time. Next slide. So there aren't really any checklists, or there's guides, and I have some resources at the end of the presentation that are certainly really good resources to have that can guide conversations and can document some of those values and expression of wishes. But I would say there isn't a detailed checklist, because again, you don't want to have a really rigid directive as to what is or isn't, because the context might look very different at the time a decision is needed. So family conflict is something that could come up quite often, especially when you're thinking about the hierarchy and the number of individuals that might be a substitute decision maker. And one of the questions that we had was, does a patient's written plan and wishes outweigh the decisions of a substitute decision maker if the patient can't speak? So the written wishes and plan inform the substitute decision maker, and it's important information for the healthcare team to have as well, because it can help with those conversations. And there certainly, I think all of us probably have examples where potentially a substitute decision maker changed their mind about what was written in a plan and made a decision that might have been contra to what the patient or the client had asked for. So the plan doesn't outweigh, because again, the decision at that point in time needs to come from the substitute decision maker. So the substitute decision maker is expected to follow the prior capable wishes. And if they don't know what the prior capable wishes are, it's in the best interests of the individual. And if they're in a healthcare setting where you have access to an ethicist, because sometimes situations arise where an ethicist is a really good resource to be able to draw on if the substitute decision maker is challenged with how to interpret a decision that they might need to make. And if the healthcare team is challenged with a decision that the substitute decision maker is making that maybe goes against what they know of the patient or the individual and what their prior expressed wishes are. And again, as I mentioned earlier, the Consent and Capacity Board is really that body in Ontario that we're able to go to when in doubt and if we have questions about whether wishes are being followed as they've been laid out or expressed prior. Next slide. Whose orders should be followed when several family members are disagreeing about their loved one's care needs? So if you have more than one person in the same category and they're all available to make a decision, but they don't all agree, they do need to come to some sort of a consensus. And as healthcare providers, sometimes we like to go with the path of least resistance and say there are 4 individuals and 3 of them agree and 1 doesn't. We think we can go with the 3, even though the 1 has disagreed. And legally, that is not the case. We do have to get an agreement from all 4 if they are all substitute decision makers. So it may require multiple conversations. It may be bringing in other members of the team to have those conversations to get consensus. And it's also having that conversation with the group for them to understand that they do have to have consensus and agreement with whatever the treatment decision is that's being proposed. So we're not able to pick and choose, although it might be easier to do so. Next slide. And we had a question around maybe what are some of the cultural considerations or differences that need to be thought about. And one thing that often comes up is around next of kin, because there can be some confusion that healthcare providers will go to next of kin in communicating or for asking for a decision. And next of kin does not necessarily mean the highest person on the substitute decision maker hierarchy. So it could be their closest relative that lives locally that's next of kin that, you know, for practical considerations would be reached out to. But when it comes to any healthcare information or healthcare consent, it would be the hierarchy. So just a lot of times our electronic medical records they still have next of kin as kind of one of those identifiers. And I'm always hoping that we will change it to be the substitute decision maker and next of kin information be embedded somewhere else. Because they don't necessarily equate to the same. And one of the other things to consider for myself living in Northwestern Ontario and a number of Indigenous communities that are remote, that when there's medical travel needed, escorts will be sent in with an individual. Quite often, there might be confusion, whether it's from the person coming into hospital. We found that it's the individual coming into hospital, that the escort is the person that would be able to make decisions and that they would be communicated with because they maybe speak the language of the individual and English. So they're that person that they're thinking is going to be doing the communication. But it's important for them to know that escorts are not necessarily what we look to for substitute decision makers when you're entering the Western health system, that there is a hierarchy that we have to follow. So when a person's coming in and their escort might be anticipating that they would be asked to make decisions and then disappointed and frustrated when the healthcare team isn't able to go to them. And I always think of this because it was an example that was brought forward to me The family was very intentional with who the escort was coming into Thunder Bay. And when the individual knew the patient very well, knew the family very well, spoke the language, but was not the substitute decision maker. So when they were trying to be part of the care decisions and the communication, they were left out by the healthcare providers, and it was a very frustrating experience for them. And then created a lot of work because then there were phone calls back to the community. There wasn't the appropriate translation services on the healthcare provider side. So having those conversations early is really important if you're working in community, to how you can ease that when they're entering a system that might not acknowledge and respect the decision-making process that was established in community. Next slide. So having an awareness of cultural, spiritual, and personal values. So again, as healthcare providers or people that are working with families, an individual, can we get an understanding of how decisions are made in their family? And who do people turn to make those decisions? And is there a way that that can get documented and captured so that if they're leaving community, it can follow them? It's really important to develop a relationship with the individual to have an understanding of what those values are, understanding the community that they may be coming from or that they're going back to, how the person identifies or relates to cultural practices, whether that's important to them, how are we capturing that information. And always when it's language, considering how do we enable access to the language that they speak. And that is an obligation of healthcare providers. We are obligated to, if they do not speak English and we're asking for a treatment decision and they need to be translated, it can't be a friend or a staff member or someone who might, it has to be an interpreter. And that can be really challenging, particularly in rural communities that may not have access to those interpreters. So there are services, though, that we can reach out to, and knowing what they are in your region is really important. Next slide. So capacity and decision making. How do you know when a client can make a conscious decision, and is there specific criteria? So there is criteria, and for all of those that are regulated on the call, my question is, do you know what the test for capacity is? If you do, maybe you could jot it down in the chat. Because if, regardless of your role, and if you are regulated and you are making a determination at a point in time whether someone is capable, my hope would be that you know what that test for capacity is. So the test for capacity is if the person reasonably understands the foreseeable and appreciates the foreseeable consequences of making a decision or a lack of decision. And to remember that capacity is a legal construct. It's not a medical diagnosis. And I think often we can forget that when we say that someone's incapable. We're thinking that is, of making a healthcare decision. We think it might be global. So once you've decided at one point in time, it might carry on, and it's not. As healthcare providers, we have to have a presumption of capacity with the patients that we're working with. And if we've made a determination that they're not capable, even if it's to take a PRN medication, are we documenting it and documenting that in that instance, because for whatever reason we determined they weren't capable of making that decision, we had to go to their substitute decision maker to ask if they could take that particular medication. And we, as the healthcare providers, assess the capacity unless there's something very specific where they're asking for a capacity assessment to be done. And then a capacity assessor can come in, and there's certain criteria that a capacity assessor has to meet to come in and do that. Next slide. And the reversibility. So a question was, is a global assessment of a patient, so I'm thinking of a global assessment of incapacity of a patient, is it reversible, or who is able to change it? So if I thinking I understood the question, and the answer would be that capacity fluctuates. So although somebody can be incapable one day, if they have an infection, if something is happening with their healthcare condition, that they've got a confusion or a delirium, that can clear, and they may be incapable at that point in time. But in a day, a week from now, sometimes even a month from now, if you think about people who have undergone surgery and have had an anesthetic, and maybe there's some delirium associated with that, that may be there for a while, but in a month it clears. A month later, they're capable of making a decision. So it can fluctuate. It does need to be reassessed ongoing. And there is no global designation for incapacity. Next slide. And then and I kept this at the end, it was around medical assistance in dying and advanced care planning. And the question was, I think, the move to medical assistance in dying and advanced care planning. So the way I interpreted that was, if you have an advanced care planning conversation, or maybe it is potentially part of someone's advanced care planning document that they created, what kind of happens with that. So without getting into a lot of detail, because medical assistance in dying is a whole other topic that could be talked about, it is a separate legal process. Advanced care planning can include values related to suffering, but there is currently no advanced consent to medical assistance in dying. There is a waiver of final consent within our current legislation, but there are very specific criteria that need to be met for a waiver of final consent. And there is a specified day that has to be identified as within that process. So they would have undergone an assessment, and they would have a specified day that was determined. So it isn't this, and I think this comes up, and it may change in the next year or so, but really looking at individuals, I think where some of this has come is individuals that might be living with dementia. And as their dementia progresses and they've identified that they are wanting medical assistance in dying at some point in time, can they give advanced consent? And currently we don't have any processes or criteria in place for that to be enabled. Next slide. So some of the resources for advanced care planning that aren't trying to sell you something, because there are a lot that are now online. If you look on Facebook and social media, there's all kinds of kits and things that you can do. Some are free, some have a cost. These are the ones that are credible, legal, for the power of attorney from the Ministry of Attorney General. But the Advanced Care Planning Ontario, or the Speak Up, is a really good reference and starting place for people if they're wanting to have some of these conversations. It outlines the substitute decision maker hierarchy. It's got some really good initial prompts and questions to ask, confirms the substitute decision maker. And then coming full circle, Planning for Your Care is a cultural resource that you can get through Canadian Virtual Hospice, and is a really good resource that has, I think they're really non-threatening questions to get people that aren't focused on death, dying, or palliative care, but really more around illness understanding, what's of value, what's important, and some questions that might be easier to initiate than being very pointed. Next slide. So I'm hoping in the last few minutes, we didn't have it. So I had a case, and I'm just going to take a pulse, Stacy. If there were many questions, if there weren't, we could kind of walk through a case for 10 minutes and just get a sense from the group.
I think you're good to move through with the case, Jill. Based on the chat, there were a couple questions that came up, but it looks like they have been answered.
Okay, so I have a case that I thought I could present. So Mr. Khan is a 70-year-old male. He has a diagnosis of advanced COPD and congestive heart failure. He has mild cognitive impairment. He has arrived at the emergency department with severe shortness of breath and pneumonia. He was receiving oxygen and IV antibiotics prior to arriving, and he's a bit confused, but he can engage in conversation. He currently lives in a retirement residence. He's widowed. Recently, he's had 3 hospital admissions in the last 6 months, all respiratory exacerbations. He's got increasing functional decline, so he's needing more help with his activities of daily living. And he's had a recent episode of delirium during his last hospital admission. From a family perspective, his daughter lives nearby. She's very involved and believes everything should be done. His son lives out of the province and states his father previously said he wouldn't want to suffer on machines. And the retirement home staff have reported that there is some tension between the siblings. So having heard that, what do you think? Who do you think is the substitute decision maker for Mr. Khan? And you can write it in the chat, or you can take yourself off mute. The daughter, the oldest child, the daughter. Okay. So he has 2 children and he's widowed. So if we think back to the hierarchy, it would be both, because he doesn't have a power of attorney for personal care. Given the information that I read, do you think that Mr. Khan is capable of making decisions today? If you were in that emergency department, do you think he would be capable of making decisions? Yes, yes. If he was a little more confused, what might you do? An assessment. Yes. Okay. So you would do that test for capacity. So knowing that both children, so in this situation, in this particular context, whatever was needed in the way of treatment, given that you've assessed that he's capable today, he's able to consent what's being proposed. But if he came in and you think about it said in the case that he had been in and he had had a delirium, and with a previous admission, if both children is the substitute decision maker and they disagree, what might you do in that situation? Now, given emergency department's probably a really bad example because nobody has time it's going to take to be able to talk to the family to the extent that's needed. But if they both disagree and you're needing consent, what process or what next steps would you make? Consent Capacity Board could consider, right? So I think in an ER situation, the Consent and Capacity Board won't be able to probably decide as quickly as is needed because it can take up to 7 days for them to receive an application and then schedule a hearing. So those are probably tricky situations where you hope that the person that you're getting in touch with, when you need to get a hold of both of them, maybe you can't get a hold of one if they both disagree. And I think in that situation, often, given Mr. Khan's, probably the daughter is the substitute decision maker that maybe would have even accompanied him into the hospital. And certainly from my own personal experience of either witnessing it or seeing, the healthcare team usually defers if the patient is incapable, to the person, the substitute decision maker that's with them. They're not necessarily asking them to produce a power of attorney for personal care, and they don't necessarily ask about another substitute decision maker, although we should be, but timing-wise, I think there's just practicalities that sometimes the decision-making process can't necessarily be followed to the full intent. So great answers. And I'm not sure if there are any other questions that came up in the chat, Stacey.
There are no new questions in the chat, but I will open it up. Oh, I do see Hurley has a question. And Hurley, I'm not sure if you want to unmute yourself and ask the question, or you can type it in the chat.
Hi, Jill.
Hi, Harley.
I just have a sort of a situation-specific question. It's a little bit different than some of the scenarios that you had described. So I work for a community living organization, and we support a lot of individuals that like young people who have intellectual disabilities, but also mental health issues and a lot of substance use issues. And one of the young women that I support, she had a couple of life-threatening um, illnesses, congestive heart failure and kidney failure. But she, because of her FASD and a couple of other issues, I don't know exactly what to attribute it to, but she's very impulsive. And so she was admitted to hospital, and then she would be there for a little while, and then she would leave. And it's like a back and forth a number of different times, just in the hospital, out of the hospital, in the hospital, out of the hospital. And it really impaired the medical team's ability to give her proper care. She had financial capacity assessment that she was deemed incapable of, but sort of like the reverse of what you said with the person entering long-term care, how just because they're in long-term care and can't live at home doesn't necessarily mean that they can't make important health decisions. But this young woman is capable of living at home independently, well supported, but probably not capable of making big health decisions. Is there any way to get sort of a standing capacity assessment for major health decisions, or is that something that would be sort of locked into other capacity assessments?
So under the Healthcare Consent Act, to my knowledge, there isn't. When we're under the Mental Health Act, there is longer standing provisions for incapacity. But I appreciate that they're really, really challenging situations. And as you've pointed out, they're going to be ongoing. So even if they are resolved this time, there's a good chance that there's going to come another time. And I think what I've learned over time is that and from the intellectual developmental disability kind of community, they've really looked at tools and resources for shared decision making. So depending on that assessment of the home environment and who, like if they're living in a group home, but they're still, that person's going to have family members, and what is their role, and are they willing and available to support? I mean, it's decision specific, so you could get a capacity done for the current situation that the team might be feeling that she's not making a well-informed decision or appreciating the consequences of that decision. But I also find sometimes with the capacity assessment for healthcare decisions, there seems to be a lot broader, a bigger latitude in determining capability than incapability, because people can make really poor decisions and understand that it's a poor decision. But with the FSAD, I mean, there's I think some complexities there. So I don't have an easy answer for you, Harley. I would say it would be looking at shared decision-making processes, and can something like that be agreed upon and put in place to support her, and who would be involved in that within that shared decision-making process, and to look at some of the tools and resources within the IDD community, because I know there's a palliative care toolkit that has recently been developed that had a lot of expertise in the development and looking at adapting some of those tools that would meet advanced care planning and decision making was a big piece of that. and how do we support individuals with that and living in a care home environment.
Thank you.
Thank you, Harley, for the question. We do have a couple more minutes. If anyone else has any questions, you can, again, either put them in the chat or unmute yourself. I can't see everybody, so if anyone has a hand raised and I'm not addressing you, please just unmute yourself and you can ask your question. Okay, seeing no questions coming forward, that's a fabulous sign that I think Jill's amazing presentation has answered so many of our questions. So thank you so much, Jill, for sharing with us today, for your presentation, for sharing your knowledge and your experiences, and answering all of our questions. Thank you to the Center for Education and Research on Aging and Health for all of your support, Stephanie, in coordinating and promoting this session, for answering some of the questions in the chat and providing some resources. I see Stephanie has also just put in the chat the quiz that was available too for testing your advanced care planning knowledge. So you can click on that link and do the quiz if you would like. And I would also like to thank everybody for taking the time to join us today on Advanced Care Planning Day, for bringing forward all of your questions, for being open to learning more about advanced care planning, substitute decision making, and healthcare consent. And, we know that that really speaks to your commitment to quality care, and we really appreciate all that you do and you being here to share Advanced Care Planning Day with us today. So thank you so much, everyone. We will send out the the presentation slides after the session today, and the session was recorded, so it will be archived in Sarah's Education Archives. So thank you so much, everybody.
Take the quiz. Take the quiz. It's a fun quiz. We don't track who responds to it, but it is. I did it. It's a fun quiz.
All right. Thank you, everybody. Enjoy the rest of your day.
Thanks, Stacey.
Thank you, Jill. That was amazing. And please
Thanks,
do complete
Stephanie.
our evaluation survey. It should pop up when you leave today, everyone. So thank you.